I am Dr. Ashita Dubey. I am a fellow at Ideal Fertility, and I will not like to waste any more time. I will start with my topic. So today I am standing against the big giant NIPT with my cool sword, and I'll be speaking for double marker and NT scan, and as a primary screening method which can be applied in the general population. My talk is not against NIPT, but against its use and its application as a screening tool for everybody, for the general population. So what are the advantages of NIPT and NT scan? It is a well-established protocol. It is integrated into standard prenatal screening practices. It can be done at 11 to 14 weeks. The NT scan adds the value. It gives the understanding of the structural anomalies. Pre-eclampsia screening can be done at the same time. It is non-invasive and it is widely available and significantly cheaper. These are the various studies which have shown that it can be applied for with a detection rate of 96% in the general population. So the most important thing which we need to understand is the cost debate over here. NIPT is fancy, but it's very expensive, while double marker and NT is something which is affordable and has been reliable. As said by AIMS, that NIPT is not feasible for routine public health. Also, Sharma et al. Stated that NT and double marker is affordable, effective. Similarly, it provides a good balance between accuracy, cost effectiveness. And because of this lower cost and familiarity, Indian women, majority of them prefer this over NIPT. Secondly, there is lack of insurance coverage by most private companies. No government policies are there on aneuploidy screening. This has proven by the study that because of this lack of insurance coverage, a lot of women do not tend to choose NIPT. Then we talk about availability and accessibility. NT scans, double markers are widely available. NIPT might not be available everywhere. There's added cost of transport. This has been clearly stated by the study. And moreover, the sample collection technique is very important in case of NIPT. The sample has to be collected via proper needle. It has to be taken in a specific tube. It has to be shaken well. And we have to maintain a specific temperature. It cannot be too hot. It cannot be too cold. So all these factors might not be applicable in all the settings, especially in rural areas. And whenever these are not maintained, there is hemolysis of blood and DNA damage occurs by the presence of maternal WBCs. These are clearly stated by a study published in BMC Med Genomics. Because of hemolysis, the chances of getting a no-call result increases. When we talk about accuracy and utility, NIPT can be considered a burger with no sides, while we are missing out on the full meal. So what is the full meal? So to understand that, we need to understand the birth prevalence. That means कितने बच्चे पैदा हो रहे हैं with these anomalies. So with trisomy 21, 18, 13, it is 2 in 1,000. Other trisomies, it is 3 in 1,000. Microdeletion duplication, 1.2 in 100. And congenital anomalies, 2 to 3 in 100. So when we look at the birth prevalence, other anomalies supersede trisomies 21, 18 and 13, which are considered to be common. So if we look for NT and double marker, we just don't look for trisomies. If we follow the ESWOG practice guidelines, we are looking at these major structural changes, and also we follow the risk assessment. We look for NT, we look for NB, nasal bone, we look for DV, we look for tricuspid regurgitation. Along with this, we calculate the uterine artery PI, which will give us prediction for preeclampsia. So NT scan, it definitely helps us in identifying the structural anomalies. And similarly, ESWOG guidelines have said that it is NT's first trimester screening is the cornerstone of aneuploidy risk assessment. FMF has stated that NIPT is not diagnostic. So definitely we need an ultrasound evaluations to assess the fetal anatomy. Then a study was done, and a review of 14 studies in various parts of the world were done, and they found when they implemented NIPT as a general screening method, there was no change in the termination rates for trisomy 21, neither there was a change in the live birth rates. Similarly, Netherlands has been one of the few countries which have implemented NIPT as the primary screening test. So what happened, the patient never showed up for the 11 to 13 week scan. At 10 weeks they underwent NIPT, they directly came at 18 to 20 weeks. So this resulted in missing of 56% of anomalies which could have been diagnosed in the first trimester. Then if we look at the ASPRE trial, if we follow the NT scan and double marker, we can do pre-eclampsia screening as well and advise ecosprin for all the patients who are at high risk. This can be missed if we just follow NIPT. Then we talk about false positives and negatives. NIPT definitely has a very low false negative rates for trisomies, which are 21, 18 and 13. But for other trisomies, for microdeletions, for microduplications, it is not so. Moreover, when we get a positive result, and everybody knows that NIPT has a sensitivity of 99%. So getting a positive result sometimes is falsely conveyed to the clinicians as well as to the patients that 99% हाँ बच्चे में तो खराबी है ही, and they go directly for termination, skipping the invasive procedure. So this has been a lot of problem in many parts of different countries. And similarly, a study was conducted in Singapore. It has showed that there's a 5% chance of failure to obtain result, and also there is chance of missing 10% of anomalies other than 21, 18 and 13. Then there's a poor positive predictive value for CNVs. These are microdeletions and duplications, and almost 1% of all fetuses and newborns have these microdeletions and duplications. All might not be expressed as an abnormality, but it is present. So the positive predictive value is lower, and ACMG does not recommend screening for aneuploidies other than 21, 18 and 13 because there is lack of validation. Then another important thing is confined placental mosaicism. NIPT में जो DNA होता है वो trophoblast cells का होता है. It is not the fetus, it is the placenta. And the placenta has some mosaic cells also. So many a times there is a chance that you diagnose these mosaic cells and label the fetus as abnormal. It is 2% for trisomy 21, 4% for trisomy 18 and 22% for trisomy 13. And also there is a study has said that women aged less than 25 years, they are more at risk of having abnormal child with trisomies other than these three. So the detection rate is lower for these women than for older women. And what to do if the mother is a known case of aneuploidy? How many of us actually do for an antenatal mother, how many of us do a karyotype screening? So if the mother is mosaic, if the mother is aneuploid, then what DNA are we detecting over here? Then vanishing twins. Everybody doesn't go for a 10-week or 9-week dating scan. What if there is a vanishing twin which has an aneuploidy and we have not detected it, we underwent for NIPT directly. So the result is of the vanishing twin or the normal pregnancy. Similarly for dichorionic twins, there are two placentas, two different DNAs. Now with NIPT, whose DNA are we detecting? A similar study was done and published in Maternal Fetal Medicine, and it has shown that the detection rate is 72% for cell-free DNA compared to the other tests. Now, no call. So many a times when we are using a GPS and we land up in a place where there is a blind spot, we don't know where to go. This is a no call. That means whenever we send the DNA for sampling, we see the fetal fraction, मतलब कि fetus का DNA कितना था, and उसके हिसाब से we get the results. So there are a lot of factors which affect this. We can get a no call if the gestation is too less, if the maternal weight is too high, sample was not collected properly, mother was on anticoagulants, there were recent blood transfusions, some aneuploidies itself is associated with a no call test, especially trisomy 18 and triploidies, and maternal associated conditions such as having a fibroid and ovarian cyst. All these affect the results. So what will be the most important model? So either you go for 10 weeks dating scan, then go for NIPT. This will miss the anomalies till 18 to 20 weeks. We go for a 10-week scan, then we go for NIPT, and then we do a 12 to 13-week scan. So over here the problem is, first we have done the NIPT, then we are going for the anomaly scan. If we find a structural abnormalities, the patient needs invasive testing. So what was the use of NIPT in this state? Then another option which we have is going for an early anatomy scan with combined screening and contingent NIPT. If the patient's financial capacities are there, they can go for NIPT. So ultimately, what question we need to answer is the baby fine or not? So NIPT is not a diagnostic test. That is why it is called NIPS. And we need invasive testing for confirmation of the diagnosis. ACMG has done a study on the Indian population, and they have clearly recommended that it is not a diagnostic test. Pregnant women in India, if you ask them to go for NIPS, they desire 100% exclusion of abnormalities. In the event of positive test, you have to confirm by invasive procedure. Women at high risk of aneuploidy should be given an option of invasive procedure. And for no-call results, in only 60% cases, a result was obtained by a second test. So directly they need to go for invasive testing. And similarly, various Indian studies have suggested that it is not the cost-effective population and not reliable for the general population. So my conclusion is, NIPT has its advantages, but it is not a confirmatory test. It has its drawbacks, which needs to be understood. Cost and accessibility may play a major role, and it cannot be applied as a general test. Thank you.
So I think it was a very mature and spirited debate. Really liked both the speakers and how they put across their points. Now, let me throw it open to the board, to the audience. How many of you think that NIPT can be a mass screening test? A show of hands. Nobody? Alkesh? At least for debate's sake. And how many of you think the combined test will still be the mass screening tool? Overwhelming majority. And I think that debate is very, very clear. So I was just noting down a few points from both the speakers so that we could have a lively discussion on that. So how do you basically say if a test, any screening test for that matter, is good or not? Okay, you have some parameters. Most importantly, like Alkesh said, how much out of 100 can you really pick up? That's what you call as sensitivity, or in screening terms, detection rate. Okay? So that tells you how technically good your test is. Then you have another paradigm for clinical precision, which is what we call as positive predictive value, or in screening parlance, you call it as odds of being affected given a positive risk, or OAPR. Okay? Which means if you do a screening test and it says there is a risk of Down syndrome, how true is that test likely to be, or how true is that result likely to be? Now, if you look at these two parameters, detection rate and the positive predictive value, or OAPR, NIPT wins hands down. Okay? I'll reserve the numbers for a little later, but NIPT has a much superior detection rate and a much higher positive predictive value compared to the combined test, right? Now let us look at negative predictive value, which means you do a test and the test says there is no risk of Down syndrome. How likely is that going to be true? So for the combined test, the negative predictive value is 99%, which means if a combined test says there is no Down syndrome, 99 out of 100 times there's not going to be Down syndrome in that baby. NIPT, negative predictive value, again 99%. So when you look at negative predictive values, there's really nothing to choose between NIPT and the combined test. Okay? So if you're trying to rule out Down syndrome, the combined test is still good enough. Now, what then are the other advantages of NIPT? Now, the combined test is very specified test that you can do between a CRL of 45 to 84 millimeters, let's say 11 to 13 weeks and 6 days. Whereas NIPT gives you a much wider window to screen. You can screen from 10 weeks till delivery, okay? And if possible, even beyond delivery if required. The other advantage of NIPT is because of its high positive predictive value, it helps you reduce your number of invasive tests. In a candidate or in a mother who you think that there is not that high a risk of Down syndrome, but there are still some suspicious markers, let's say for example, you just need to be sure that the baby is normal rather than pick up Down syndrome. In such cases, NIPT would be a good test because it helps you bring down the number of invasives. Remember, invasives are expensive, and more importantly, as Alkesh said, they also carry a risk of miscarriage. So that's how NIPT in the first place came as a relevant test, because you could bring down the number of invasives. But what are your factors against an NIPT? So I take heart from what Ashita was mentioning. Now, as she very clearly said, be under no misconception that NIPT is a diagnostic test. No. That's why she said it's called as NIPS and not as NIPD. If it was a diagnostic test, it would have been called as NIPD. Now, to say a test is diagnostic, your sensitivity should be 100%, your specificity should be 100%, your positive predictive value should be 100%. Okay? NIPT still has not gotten there. Your detection rate is very high, but not 99% as the NEJM paper published. Your positive predictive value is very high, not 99% as the NEJM paper said. But in real life, when you factor in what she said as the no-call rates, your detection rates come down to, let's say, at best, 96, 97%. Okay? On the other hand, the combined test with additional markers also give you around 95% detection rate. So there's not a significant leap in terms of detection rates when you talk about NIPT versus the combined test. The second thing is a positive predictive value. The Achilles heel of a combined test is its very, very poor, abysmally low positive predictive value. I'll give you numbers. If you say that the combined test is positive, if a mother comes to you with a positive combined test, the OAPR is 1 in 22, which means if you translate that to positive predictive values, it is only 3% if the mother is below 35 years. Which means if a 25-year-old mother comes to you with a positive screening test on the combined report or the combined test report, 97 out of 100 times that baby is going to be normal. Are you understanding what I'm trying to say? The positive predictive value is only 3% for a combined test. So which is what we face in real life. Every day, 10 mothers come to you with a positive screening report. And your job is to sit down and tell them, look here, 97 out of 100 times, if I do a confirmatory testing, your baby is going to come back as normal. So that's how poor the positive predictive value of the combined test is. But having said that, the positive predictive value of NIPT is also not 99% as is believed in most places, because if you look at that NEJM paper that Alkesh was showing, and you read the fine print, the prevalence of Down syndrome in that cohort was 1 in 8. Okay? Which means they've looked at a very high risk cohort, meaning screen positives was their starting point. So obviously those mothers, babies are anyways at high risk of Down syndrome. So it was in that very high risk cohort with a very high prevalence of Down syndrome that they got the positive predictive value of 99%. Okay? Let me give you a very simple example. You walk out today, okay, you find very dark clouds above your head. And imagine that you're in Chennai versus you're in Cherrapunji. You see dark clouds. Where is it likely to rain more? Cherrapunji, obviously, because the prevalence of rainfall is so high in Cherrapunji versus dry and arid Chennai. The same thing applies here. If you look at the positive predictive value of a test in a population that has got a very, very high prevalence of Down syndrome, it is very likely that you get a high positive predictive value. Whereas if you look at the same positive predictive value in a population that has got a very low prevalence of Down syndrome, your positive predictive value will automatically come down. So in real life, if you factor in all of these, the positive predictive value of NIPT is somewhere around 63% at best. Okay? So do not be under a misconception that if you see a positive NIPT, you can offer termination to that pregnancy, because still there could be false positives. And you heard her eloquently mention all the reasons for a false positive. No call rate, sample assay failure, technical, if you're not collected in the tube properly and shaken, etc., etc. So again, so if you look at real numbers, combined test detection rate is around 95%, NIPT detection rate is around 97%. Combined test, your negative predictive value is 99%, NIPT negative predictive value is 99%. Combined test positive predictive value is 3%, NIPT it's 65%. Now, if the mother's age is 35, the NIPT, the positive predictive value of the combined test is slightly higher, but even then it's only a 10%. 90% of the times, even if the mother is 40 years and comes to you with a positive screening report, the baby could still be normal. So if you factor in all of these, yes, in terms of technical precision, as well as in terms of clinical utility or clinical precision, NIPT definitely outscores the combined test. But the topic that was given was as a tool for mass screening, as a primary screening in the population. That's where costs come into the picture. Now, if the NIPT was, let's say, 3,000 rupees, then there's absolutely no argument that NIPT would be your ideal screening test. But the cost of NIPT is anywhere between, I don't know what labs offer here, but in our place it's anywhere between 10 and 15,000, whereas a combined test is 1,800 rupees. So when you talk of a population-based screening, it's always cost that becomes a major determinant factor there. So therefore, as a mass screening tool, as Ashita rightly mentioned, we would all still go for the combined test and then use NIPT in a contingent model. If there is an intermediate risk, you can go for the NIPT. So in our population, in the Indian context, how really can you apply NIPT usefully? So let's look at examples from around the world. In the UK, what they do mandatorily the combined test for every woman. Okay? Only if the combined test shows an intermediate risk, which of course is defined as any risk between 1 in 150 and 1 in 1,000 as per the NHS guidelines, only then you can do the NIPT. Okay? No, you can do it on request, but then it's out-of-pocket expenditure. But if the NHS has to pay for the NIPT, you have to have undergone a primary mass screening test, and that test shows an intermediate risk. Yes, the NHS will pay for your NIPT. That's how it works in the UK. In the US are much more liberal with everything, we know that. So they say, we have all of these tests in our market, you do whichever you feel like. Okay? And it's all industry driven, it's all insurance companies driven. So it's an understanding between the medical fraternity and the industry there. So that's not an example that you can extrapolate to the rest of the world. Now in India, as she very rightly said, we do not have a national policy on screening as yet. So each one is left to his own. So I cannot tell you that this is the right policy for screening. I can only give you my policy. So what we do is we follow what we call as the 100 to 1,000 rule. Okay? The 100 to 1,000 rule is very simple. Any mother, before 22 weeks of gestation, I'll tell you why, if she throws up a risk of 1 in 100 to 1 in 1,000 for aneuploidy, those mothers are the ones who are offered NIPT. For example, if a mother is 40-year-old, okay, her risk is 1 in 100, straight away NIPT. Or 38-year-old, let's say 1 in 100, you offer NIPT. She's undergone a first trimester combined test. Another example, she's undergone a first trimester combined test. She comes to the anomaly scan, you find echogenic focus in pelvic cases. Her risk goes up to, let's say, 1 in 749. Again, 100 to 1,000 bracket, offer an NIPT. So for any reason, if a mother's risk at the end of your assessment is between 1 in 100 and 1 in 1,000, we offer an NIPT. So that's again very similar to the contingent model that was being mentioned. Now the advantage of this is, in olden times, your screening cutoffs used to be 1 in 250. Okay? So if I say I'll offer NIPT to the intermediate risk of 1 in 250 to 1 in 1,000, it does not achieve the goal of bringing down your invasive testing. You understand what I'm trying to say? You offer invasive testing to all your high-risk mothers. And if your high-risk cutoff is 1 in 250, you will still offer the same number of invasives that you were offering before. In addition, you will offer an NIPT to the intermediate risk group. So the whole aim of introducing an NIPT, of bringing down your invasives, is not happening. So that is taken care of when you shift your cutoff for high risk from 1 in 250 to 1 in 100. So any mother who has a risk of 1 to 1 in 100 is high risk. You do an invasive testing. 1 in 100 to 1 in 1,000 for whatever reason, you call it as intermediate risk and you do NIPT. So that helps you bring down your number of invasive testing. You also have the advantage that you're not going to miss out on Down syndrome. And 1 in 1,000 is anyways low risk, so you don't need to do any of these. So the final verdict, in my opinion, is as and when NIPT costs come down, or until such time that NIPT costs become comparable to the combined test, for mass screening, we would still use the combined test. And I'm sure all of you have already agreed with that. The caveat to that is, how will the cost come down if we don't do it? So the only way to bring down the cost of any test is to keep doing more and more tests. When NIPT was launched in India, the uptake was 1 NIPT per month in our unit. That has now gone up to 20, 25 per month in our unit. And obviously, if you look at the time when NIPT was introduced, the cost was 26,000. Now it's come down to 10,000, only because more and more NIPT tests are being ordered. So the future is very much in favor of NIPT, but as far as this point in time is considered, we will still go with combined test as a mass modality screening test. Agreed, all of you? Thank you. It's a very tough question to answer. If the couple are willing to pay for the NIPT, there's no harm in doing the NIPT and doing anomaly scan at that visit, or maybe at 16 weeks, so you can do an early anomaly scan. But if she's not affording the NIPT, then of course you can still go back to the early anomaly scan plus quadruple test, which gives you a combined detection rate of around 80 to 85%. Yeah, so that again, the sensitivity or the detection rate of the quadruple marker is around 60-65% at best. When you combine that with the anomaly scan, you do a genetic sonogram, it improves to maybe 85%. It's still inferior in detection rates compared to the NIPT. So if the NIPT is an option at that point in time, particularly when you have not done the first trimester screening, if they're willing to pay for the NIPT, NIPT can be done, but that will not let you not do the scan. You'll still do the scan to pick up anomalies. Yeah. So it can be, you can offer an NIPT if they're willing to take it up. Yeah.
We should go ahead with the next session.
I'd like to thank all the speakers of the session and all the chairpersons of the session. We'll request all the chairpersons to join us on the stage, and I'll request D'Pankar sir and Pradna madam to join us on the stage for felicitating the chairpersons of the session 1. There is important announcement for the PG students. They are those who are joining the quiz, they are requested to meet Dr. Deepti Gupta in the lobby at around 12 p.m. Request all the chairpersons to please join us on the stage and take the proceedings further.
We welcome you, Devashish, for this FetusC0n.
Thank you, ma'am. Good morning, everyone. I am really thankful to Dr.D'Pankar Banerji sir for giving me this opportunity to talk to you for monochorionic twins. And after finishing this session, this lecture, I am sure that most of you will be able to determine the complications of the monochorionic twins quite confidently, and you will see it's quite easy to understand the monochorionic twins. But before going into the details of the monochorionic twins, let us discuss about the multiple gestation, the basics of multiple gestations. We all know that the perinatal mortality and morbidity is higher with the multiple gestations and twin pregnancies, and that too it is much higher with the monochorionic twins. Therefore, the determination of the chorionicity is very important. To determine the chorionicity, the best time is at the 5 to 9 weeks. That at the 5 to 6 weeks, on ultrasound examination, you will see 2 gestational sacs, and this is dichorionic pregnancy. At 7 to 9 weeks, a single sac with a single sac with 2 embryos and 2 amniotic cavities is seen. That is, it is monochorionic diamniotic pregnancy. But at the time of the anti-scan, that is 11 to 13 weeks, you will be seeing a single placenta or 2 placentas. So if a single placenta is seen and a membrane is seen, then the membrane can be thick and thin. The thicker membrane, which is broadened towards the base, is the lambda sign, and it is seen with the dichorionic pregnancy. It is thick because the chorionic tissue gets protruded between the membranes, the amniotic membranes. So it is a thicker membrane and produces this lambda sign. It is very diagnostic of the dichorionic pregnancy. However, in monochorionic pregnancy, there is no chorionic tissue in between the amnion. So it is the single thin imperceptible membrane is there, and which is directly attached to the placenta. It is monochorionic pregnancy. So the concept of the zygosity also is also there, in which dizygotic twins are almost always dichorionic, while the monozygotic twins can be dichorionic or monochorionic. If it is depending on the time of the cleavage. If cleavage occurs at 1 to 3 days, then it is dichorionic. If cleavage occurs after 3 to 4 days, it is monochorionic, and so on, monochorionic, monoamniotic, and as conjoint as well. So dating of the pregnancy is also important, because we have to diagnose the growth restriction. So pregnancy dating at 11 to 13 weeks we determine by the CRL of the longest fetus. CRL of the longest fetus is taken for the dating of pregnancy. Also for IVF conception, because multiple pregnancies are common with IVF conceptions, the embryonic age of the fertilization is taken. And remember, CRL discordance will be there most of the time, and this should not be used routinely to identify pregnancies at high risk for adverse perinatal outcome. So therefore CRL discordance is avoided in pregnancy dating. Apart from that, labeling of the twin is very important, because we don't want the labeled twin as twin A in the first trimester and that twin become twin B in later gestation. So the dating, we have to use the universal protocol, and for that the internal os should be used as the referring point. So the twin which is for in early gestation, the sac which is nearer to the internal os should be taken as sac A, and away from internal os should be taken as sac B, and so on. For triplet, quadruplet, the sac which are more away from the internal os should be taken as C, D, E. Apart from that, if you are getting pregnancies at 18 to 14 weeks, to label them as the twin A or twin B, then the placental attachment which is nearer to the internal os should be taken as twin A, which is away from the internal os should be taken as twin B. This is the ICSI guidelines for monochorionic twins, and the after routine scans at 16 weeks and after 16 weeks, every 2-week scan should be performed in case of monochorionic twins, and in case of dichorionic twins, every 4 weeks scan should be performed. And remember, after target scan, all the scans should we should go for fetal growth, amniotic fluid, umbilical artery PI, and the MCA peak systolic velocity to diagnose the complications associated with the monochorionic twins. Before going into the details of the monochorionic complications, we should know about the angioarchitecture of the monochorionic placenta, and it is very important to understand all the pathophysiology behind it. The monochorionic placenta has 2 types of anastomosis. There are superficial anastomosis and the deep anastomosis. That superficial anastomosis are larger anastomosis and fewer in number, and these anastomosis are arterio-arterial or veno-venal. That is, there is no pressure gradient between the two. So the blood flow between these anastomosis is bidirectional. Blood can flow from this side to this side, anywhere. But in the deeper anastomosis are arteriovenous anastomosis. So there is a pressure gradient from arterial side to the venous side. So the fetus attached to the arterial side will always be a donor, while the fetus which is attached to the donor side, venous side, will always be a recipient. So there is a net pressure gradient developed between the arteriovenous, and in all monochorionic pregnancies there will be deep anastomosis and the superficial anastomosis. But because of the superficial anastomosis, these are the protective anastomosis. So whatever pressure gradient generated by these deep anastomosis, these superficial will compensate the imbalance generated by these arteriovenous anastomosis. So these superficial will be protecting the fetuses from the deeper arteriovenous anastomosis. But if there is imbalance developed because of the larger number of arteriovenous and fewer number of the superficial larger anastomosis, then the complications will develop. These are the complications of the monochorionic twins, the TTTS, SFJR, TAPS and TRAP. To begin with, let us discuss about this case. This is a 17-weeker fetus, twin pregnancy, fetus A. You can see there is polyhydramnios. The single largest vertical pocket is 8 centimeter, the urinary bladder is well visualized, and the ductus venosus PI is increased for this fetus, which is looking quite normal. In fetus, the fetus B is somewhat crumpled in appearance, showing flexed limbs, and at the folding of the fetus, a thin membrane with a small amount of amniotic fluid is seen with echogenic contents, and the fetal urinary bladder is not visualized in fetus B. So to summarize, it is a 17-week, some growth discrepancy is there. Definite oligopoly sequence is there. The fetus is trapped against the uterine wall, fetus B. Urinary bladder discordance is there. Persistently filled bladder for fetus A and barely filled for fetus B. Effective fetal weight is small for fetus B. Ductus venosus PI is abnormal for larger twin, while it is normal for twin B. And the umbilical artery PI is normal for the larger twin, while it is abnormal for twin B, the smaller twin. So this is twin-twin transfusion syndrome stage 3. Now how we come to twin-twin transfusion syndrome? In twin-to-twin transfusion syndrome, there is larger arteriovenous anastomosis. So there is a net pressure gradient from this donor twin to the recipient twin. So the blood will flow from a smaller twin, that is a donor twin, to the recipient twin, resulting in the hypovolemia in the smaller twin, donor twin, and the hypervolemia in the larger normal looking twin. Because of the hypovolemia, you get the signs on ultrasound. The donor twin will always be hypovolumic. Because of hypovolemia, you will get oligohydramnios, persistently non-filled urinary bladder. Urinary bladder will not be visualized in donor twin. And the umbilical artery will get abnormal. And because of the anhydramnios, the fetus will be trapped against the uterine wall. Sometimes the membrane will not be seen because the membrane is opposed to the fetus surface. In the recipient twin, because of the hypervolemia, there will be polyhydramnios, and the urinary bladder will be persistently filled, and the ductus venosus will be abnormal because of the hypervolumic changes, and cardiomegaly will also be seen because of the hypervolemia. Quintero has developed the stages for the twin-twin transfusion syndrome, and these stages are just for our understanding. These are non-sequential stages. The fetus don't follow these stages. You can get stage 5 directly from stage 1. So there is no correlation. However, for our understanding and management, these stages are used. So in stage 1, there is definite oligopoly sequence. In stage 2, the bladder discrepancy will be seen. In stage 3, Doppler parameters will go abnormal. In stage 4, hydrops will develop. And in stage 5, there will be demise of one or both fetuses. The management of TTTS is the gold standard is the fetoscopic laser photocoagulation and the Solomon technique. That is the treatment of choice for stage 2 and beyond. For stage 1, the close weekly surveillance can be done. Now we will discuss about a second case. In this case, this is a 22-weeker fetus. The fetus A shows somewhat flattened face because of the little bit of oligohydramnios. The bladder is well visualized. Umbilical artery PI is increased. Ductus venosus is normal, and the cord insertion is marginal for this fetus. There are some other signs in this fetus also, like persistent left superior vena cava and the persistent right umbilical vein. In fetus B, there is little bit of more liquor, but it is not poly. Umbilical artery is normal, cord insertion is normal, and the urinary bladder is well visualized. So in these loops also you can see little bit of oligohydramnios here. So to summarize, the twin A is 21 week and it is 22 week, fetus B. The oligopoly sequence is not that much. Little bit of liquor is little bit reduced for twin A. Urinary bladder is normal. Effective fetal weight is less for twin A. And the umbilical artery PI is also increased for twin A. And the MCA PI is normal and the cord insertion is marginal. So this is selective fetal growth restriction of twin A type 1. The selective fetal growth restriction is because of the unequal sharing of the placenta. It is like a seesaw. If you stand more near to the placenta center, the balance will be more and the sharing will be easier. But if you stand very away from the center, then the sharing will be less. So if the cord is filamentous or marginal insertion for any fetus, and one of the cord is normal, that is unequal sharing of the placenta is there, and because of that one fetus get a smaller amount of the nutrition and flow while the other gets normal amount. So that fetus will become smaller and growth restricted. This is the basic pathophysiology of the selective fetal growth restriction. And SFJR is defined in two guidelines, in ISIOG and FMF. ISIOG says the effective fetal weight of less than 10 centile, and the FMF says effective fetal weight of less than 5th percentile. I personally use ISIOG guideline because why to wait for 5 more percentile to fall when you can diagnose the condition at the 10th percentile. So for grading of the SFJR, it is of 3 types, type 1, 2 and 3. Type 1 is the umbilical artery PI is increased, however still the flow is maintained, forward flow is maintained, diastolic flow. While in type 2, the flow in the diastolic flow is absent or reversed. In type 3, the diastolic flow is unpredictable. Sometimes it is present, sometimes it is absent, sometimes it is reversed. So the type 1 has the best prognosis because the fetus can be monitored weekly and can be carried up to the 34 week if the flow is maintained, and then delivered at 34 weeks. However, for type 2, the prognosis is quite guarded, and the ductus venosus and other parameters can be used to monitor the fetus, and if the growth is not happening and if the PI get further deteriorated, then the pregnancy have to be terminated. For type 3, it is unpredictable because the flow is unpredictable, and it is because of the superficial anastomosis in the placenta. The arterio-arterial and the veno-venal large anastomosis are there in the placenta, and because of that, in type 3, the flow is biphasic, or it is sometimes reversal and sometimes forward flow in umbilical artery. Because of that, it is unpredictable. So for selective fetal growth restriction, follow-up is important, and associated complications like TTTS and TAPS should be ruled out, and follow-up is essential for decision making. For twin anemia polycythemia sequence TAPS, in TTTS you have seen there are large anastomosis giving the larger amount of blood to the other fetus. However, in TAPS, there are a smaller capillary level anastomosis are there. So the large amount of blood cannot flow from one fetus to other. Because of that, in TTTS, there is net increase in the hemoglobin level in TAPS. While in TTTS, there is net increase in the blood volume leading to the hypervolemia. While here, there is increase in the hemoglobin concentration only. So you can see the volume of the plasma that is quite that is increased in TTTS, while it is the hemoglobin level which is increased in TAPS. That's the basic difference, and it is because of the anastomosis which is small in TAPS and large in TTTS. The diagnostic criteria are quite simple. The MCA PSV should be taken, that is if it is more than 1.5 multiples of median in the donor twin and less than 1 in the recipient twin, then it is the diagnostic of TAPS. Other criteria are the placenta which is enlarged and echogenic on the donor side. It is the echogenicity of the placenta, it is the donor side of placenta, while the placenta which is thinner and sonolucent, it is the recipient side of the placenta. Apart from that, polycythemic twin will show the hypoechoic liver, that is another thing. The Leiden has developed a staging that is to diagnose TAPS, and it is basically on the basis of the MCA PSV only. If the difference between the two twins MCA PSV is more than 0.5, it is stage 1, more than 0.7, it is stage 2. And if there is cardiac compromise of the donor, then it is stage 3. and if the hydrops develop, it is stage 4, and if one or both fetuses die, then it is stage 5. So the basic difference between the TTTS, SFGR and TAPS is there is fluid discordance, oligopolysequence in the TTTS, which is not that much in SFGR. The urinary bladder discordance, it is the diagnostic of TTTS. Estimated fetal weight of less than 10 centile, it is diagnostic of SFGR. MCA PSV, which is more than 1.5 in donor, it is diagnostic of TAPS. Ductus venosus abnormalities are seen in the recipient in the TTTS, while it is seen in smaller twin. That is, the larger twin will show ductus venosus abnormality in TTTS, while the smaller will show abnormal ductus venosus in SFGR. Placental abnormalities like one side is thick, other side is thin is seen in the TAPS. Now we will discuss about our last case. In this case I encountered in the medical college. Here you can see one hydropic fetus with deformed legs, and on color Doppler the flow in the umbilical artery is reversed. You can see the flow that is blue, and this is blue. This is going away from me, that is, it is going towards the fetus. The umbilical artery flow is always away from the fetus. It should not be towards the fetus. So here you can see large anastomotic vessel and the flow in the umbilical artery. Here the cardiac activity was not seen in that twin, and the other twin was normal twin showing cardiac activity, and the acardiac twin developed the hydrops, and there was severe polyhydramnios. So to understand this is a TRAP, that is twin reversed arterial perfusion syndrome. To understand that, the TAPS, there is anastomotic arterioarterial large anastomotic vessel in the placenta. The umbilical artery carries deoxygenated blood from one fetus. So flow in the normal fetus in the umbilical artery is normal. It is carrying blood towards the placenta. Now because of the anastomotic vessel, the same blood goes towards the other placenta. However, that twin is already dead or already vanishing twin, but because of this anastomotic vessel, that the lower part of the body is still developing, because umbilical arteries unite with the iliac vessels. Iliac vessels supply lower limb, and that too with deoxygenated blood. So the upper part of the body fails to develop because it is not receiving the enough blood supply. So this is the TRAP sequence. The lower half is not developed, lower half is developed because, and it is acardiac. So incidence is quite less, it is 1%, and the twin which is pumping the blood is called the pump twin, and the twin is which is receiving the blood is the parasitic twin. And the diagnosis is very easy. There will be a malformed large acardiac twin with hydropic changes. Umbilical artery shows reverse flow in the acardiac twin, and the pump twin will show signs of cardiac overload like cardiomegaly, pericardial effusion or hydropic changes, and polyhydramnios will be there. To understand all the different complications of the monochorionic twins, this is the flow chart I have developed. If you have determined the chorionicity, the monochorionic twins, look for the cardiac activity. If the one twin is malformed or acardiac, it is TRAP. If both the twin shows cardiac activity, then look for the oligopoly sequence. If the oligopoly sequence is present and the urinary bladder is not visualized in one twin, then it is TTTS. If the oligopoly sequence is present or absent, but it is not that much, and if the effective fetal weight is less than 10 centile, then it is SFGR. If oligopoly sequence is absent, there is effective fetal weight is normal, but the MCA PSV is showing more than 1.5 multiples of median, then it is TAPS. To summarize, always determine the chorionicity of the twin and label as per protocol, taking internal os as the referring point, and follow standard protocol for screening monochorionic twins, assessing every 2 weeks, and always keep a close eye on the oligopoly sequence and bladder discordance, and discuss treatment options every time. Thank you.
Congratulations, Devashish. Yeah.
No, these complications don't occur in DCDA. These are because of the placental sharing, because of the anastomosis. DCDA has different placentas, so they cannot occur in DCDA. DCDA is like a different pregnancy. DCDA is like two twins in a single uterus. So DCDA does not develop these kind of complication, only monochorionic twins.
Thank you.
Congratulations, Devashish. Very nice lecture and very interesting cases with a very good explanation. Thank you for the lecture.
Thank you.
Now I am inviting the next speaker, Dr. Vivek Krishnan.
Vivek, while you are arranging the slides, with the follow-up of the NT and NIPT, I have one query. If there is an abortion and we do a product of conception genetics or get the aneuploidy in 12 weeks pregnancy aborted and we get trisomy 21, does this result affects the next pregnancy risk estimation?
So if I understood right, you have done abortus karyotyping, so microarray. It came as trisomy 21. What is the risk in the next pregnancy? Okay, so yes, so the subsequent pregnancy risk of a mother who has had a previous Down syndrome is 1 in 100 or 1% or age-based risk, whichever is higher. For example, if you have a 44-year-old mother coming to you, the risk of 44-year-old mother carrying a Down's baby is 1 in 35. So you'll take that as a starting risk. But if it's a 34-year-old mother who's coming to you, who's had a previous Down syndrome baby, her age-based risk is 1 in, let's say, 1,000. But because she's had a previous Down's baby, you will take that as a higher risk, which is 1 in 100. So very simple, it is 1% or 1 in 100 that you will take unless the age-based risk is higher than that. If there's a mother who's had a previous Down syndrome baby, in the subsequent pregnancy, her starting risk or a priori risk, as was mentioned, is 1 in 100 or her age-based risk, whichever is higher.
If she had a pregnancy with not a live baby with Down syndrome, but had an abortion and I did a conceptus microarray.
Doesn't matter.
Doesn't matter.
It's the same thing. It's the same thing. It's still 1 in 100 because if it was because a lot of Down syndrome babies do abort during the course of the pregnancy. That's why your risk at 12 weeks for Down syndrome is not the same as the risk at 30 weeks.
That means if a lady who is 35 years old and
Yes.
had an abortion or had a miscarriage and
Yes.
we did a product of conception
Yes.
and it was trisomy 21 or any other trisomy,
yes.
then if she conceives again, that definitely her a priori risk starts
higher.
from 1 in 100.
Yes, yes.
This is very important. Why? Because we are cutting off the limit of 1 in 250 for amniocentesis. Here now they have started with 1 in 100 and 1 in 100 to 1 in 1000 NIPT and after 1 in 1000 no risk. But the thing is we have to start with not age risk with previous history as a priori risk and then do the combined test and then read the risk assessment. This is the way I think.
Yes, sir.
Thank you.
Second pregnancy, they have risk of 1%. That means we should offer invasive test directly.
NIPT. Because as I said, 1 in 100 to 1 in 1000 is NIPT.
Okay.
You can offer NIPT.
NIPT. Sir.
Provided your scan does not show a marker.
Yes.
You do a scan and there is increased NT and absent nasal bone, then obviously it becomes invasive testing. Scan is normal, then you can offer. Double marker, because the starting risk is so high, it's very high likely that you will get a positive risk anyways, and then you will have to go for the NIPT. So you can offer NIPT if she's not affording. There's no harm in doing a double marker, but make sure that the lab takes 1 in 100 as the starting risk and not her age-based risk.
Yes.
Yeah.
Okay. Thank
Right.
you, Vivek.
Yes. So the last time I was here a couple of years back, we spoke extensively about rhesus alloimmunization. So this time I've just restricted myself to 5 key messages that would convey the current concepts and understanding and our understanding of rhesus alloimmunization. Now, the first key message is that we need to understand that irrespective of the mother's blood group, there is no mother who is 100% immune to alloimmunization. Even if the mother is rhesus positive, there is still a small chance that there could be an alloimmunization that's happening from non-rhesus antigens. So what we need to understand is that the red blood cell, the RBC as we call it, has got around 50 antigens on its surface. It's not just the rhesus antigen. You have the ABO antigens, you have the rhesus antigens, you have the KEL antigens, you have the Duffy antigens, you have the Louis antigens, you have the Smith antigens. You name it, there are close to 50 antigens on any red blood cell surface. And all of these 50 antigens can potentially produce antibodies if the mother is negative to that. Okay, if you have a fetus that is positive for one of these antigens, but the mother is negative, there is an incompatibility of that particular antigen, and therefore the mother can develop antibodies. And half of these antigens, of those 50 antigens, have been documented to cause fetal or neonatal alloimmune problems. Okay? And these have been listed in this particular table, as you can see here. You can see very clearly that it is not all capital D antigens. It's because capital D is a big brother, it's the most common, the most prevalent, the most dangerous of these, that we always attribute alloimmunization to the capital D antigen. But remember, there are antigens or antibodies that are even more dangerous than the capital D antigen. For example, KEL and Duffy antigens are as dangerous, or if not more dangerous, than the capital D antibodies. So that's why they say KEL kills and Duffy destroys. Okay? So what you need to understand is that it's not always D antibodies. It's not even always rhesus antibodies. It could be non-rhesus, non-D antibodies that could also cause a maternal alloimmune response. And therefore, we keep saying that you have to offer an indirect Coombs test to all women at booking. And every time I say this, I get a few glares, especially from senior obstetricians, like, ye kya keh raha hai is? Okay? Because why would you need an ICT in a mother who is rhesus positive? So for the same reason that I told you, even rhesus positive mothers could be occasionally alloimmunized from one of the other antibodies. These are 3 Indian studies, not from anywhere outside India. These are 3 Indian studies, one from Vellore, one from Delhi, and one from our own center, where we looked at the prevalence of rhesus antibodies, and we found out that even rhesus positive mothers could have alloimmunization, although the numbers are very, very small. But it is still a possibility. So it makes sense to try and offer an indirect Coombs. It's just a very simple test, a very cheap test, but you might make a difference between life and death to that mother who probably is alloimmunized to a very rare antibody. Now, even if you're not willing to do that, okay, I still will not offer ICT to all my rhesus positive mothers. Makes no sense because you might pick up one in my lifetime, so I don't want to do that. Fair enough. But at least when you suspect fetal anemia on the ultrasound, at that point in time, you should certainly offer an ICT as your first line test. And how do you suspect fetal anemia? The mother complains of decreased fetal movements. That's the first sign or first symptom of fetal anemia, because an anemic baby will try and conserve whatever oxygen it is left with. So it stops moving. That's the first and immediate response of the fetus. So if a mother who has been perceiving good movements suddenly feels that the movements are coming down, please do give weightage to that and think of anemia in the fetus. If the scan is also suspicious of anemia, then at that point in time you would certainly want to do an ICT. So also if there's a very high MCA PSP, as I said, or early hydrops, because all of these could be telling you that the baby is anemic, and we know for a fact that the most common cause of fetal anemia is not fetal-maternal hemorrhage, is not parvovirus infection, but is alloimmunization, most commonly from rhesus alloimmunization, but occasionally from non-rhesus antibodies as well. The second key message is that ICT positivity does not equate to fetal anemia. I think all of you would agree with that. Because as I said, all of these the 25 antibodies that have been known to cause human disease will show a positive ICT. But if you look at the table quite closely, you would realize that not all of them cause fetal alloimmune responses. And even in those that cause a fetal alloimmune response or anemia, the symptomatology or the severity of the disease can quite significantly vary. Which is why these antibodies that have been known to cause fetal or neonatal alloimmune thrombocytopenia have been grouped or classified into 3 groups. Group 1 being the ones that are most commonly associated with clinically relevant hemolytic disease in the fetus or newborn. And this, as you can see, includes all the rhesus antibodies, capital E, small c, capital E, small e, and capital C, but also includes the 2 dangerous fellows that I spoke about earlier, the KEL and the Duffy antibodies. Now, group 2, you would exercise a little bit of caution because some of them might occasionally cause severe anemia, but group 3 is very, very benign, and if you find very, very high titers of these antibodies, even then there is no chance that the fetus is going to get anemia. For example, I do an ICT positive, ICT test, it comes back as positive. I do the antibody and it tells me that's a Lewy B antibody, which falls into group 3 here. That is Lewy B antibody. Even if the titers are 1 in 10,000, I would just reassure the mother saying that, look here, your antibody is very, very benign antibody. There's no chance that your baby is going to get anemic in this pregnancy. So you don't have to keep following up that mother after that. Now, how do I find out which antibody amongst this list is there? Because the ICT is only going to tell you that there is antibody. ICT positivity means there is some antibody in the mother. That antibody could be anything, any of these 50 or 25 antibodies that we spoke about. How do I find out which antibody is sitting in my mother? Is when I order a test called a antibody identification test. Now, these are basically panels that will look at each of these antibodies. You have 8-cell panels, 16-cell panels, 32-cell panels, 256-cell panels, where the transfusion medicine expert can exactly elucidate what antibody or antibodies are there in your particular ICT positive mother. And it's only if it is a strong antibody, or the class 1 or class 2, or group 1 or group 2 antibody that is there in this mother, that you would suspect the fetus to be at risk of anemia. Now, it's not enough that you have a strong antibody. That strong antibody should be present in a sufficient quantity to cause anemia, and that quantity is what you call as critical titers. Now, this differs from lab to lab, and it is mostly 1 in 8 or 1 in 16 in most labs. Now, having said that, there's a catch here. Now, different labs look at titers by different methods. Okay, you have something called as the tube agglutination method, which is what most medical colleges would follow because that is the gold standard, age-old testing method. But it's a little cumbersome to do. You need a doctor, a trained doctor, to really sit there and read these results for you. It takes time, and therefore, what most private labs or commercial labs these days have resorted to is what we call as the column agglutination method or the gel assay, as you can see it printed in the reports. Now, the advantage is, of course, it's very easy to do. You don't need a doc. You can do it with a technician. The endpoints are very standardized. You don't need an expert to say if this is ending there, that's starting there, and you can do it at a mass level. The turnaround time is very quick. So there are lots of technical advantages from a lab's perspective. But the problem for us clinicians is that we need to understand that gel titers are oftentimes 3 to 4 times or 4 folds higher than your tube titers. For example, if you have a tube titer of 1 in 8, which is below the critical titer of 1 in 16, and you're doing it by the gel method could actually show a titer of 1 in 128. So that's the problem with gel titers. They're very, very sensitive, but they also give you on an average 3.4 folds higher titers than the tube methods. And remember, the critical titers we have been following all this while are based on tube titers. Your standard treatment protocols are based on tube titers. All your textbooks describe tube titers. So if you're following the tube titers for practice and the lab gives you the gel titer, you have a conflict. So you need to understand exactly what technique the lab has used. If it's a gel titer, you need to look at higher titers as your critical titer, or you should have a gel titer critical value, which is what we try to do in our setting. So we undertook a study with our transfusion medicine department and tried to find out a critical titer for the gel method. And what we found out was that if your critical titer for the tube is 1 in 16, multiplied by 4, and that becomes your critical titer for the gel method. So for gel method, it's usually around 1 in 64. So if a lady comes to you with a titer value of 1 in 32, the first thing you would do is to look at the methodology. If it's been done by a gel method, you can still probably reassure her. If possible, you can repeat it by the tube method, or you can follow the critical titer for the gel method. But because it's very, very sensitive, the critical titers can keep changing this way, that way. But on an average, it's around 4 folds higher than your tube method. Now, assuming that the antibody is a strong antibody, assuming that the titer is above the critical titer, that again does not mean that the baby can get affected. For the baby to get affected, the baby has to be incompatible to that particular antibody as well. So these 3 criteria have to be satisfied if an ICT positive mother has to have fetal anemia. You should have a strong antibody, you should have significant amounts of antibody, and it's also important that the fetus inside her is incompatible to that particular antibody. So how do you find out? Can you do a fetal blood sampling and say if the baby is incompatible or not? You can do that, but it's an invasive testing. You can alternatively follow up with MCA Dopplers and try and find out if the fetus is anemic. But more recently, we have the advantage of offering NIPT there as well. There's 1 or 2 companies in India that now do NIPT for fetal blood group. Okay, for fetal rhesus status more precisely. They don't do it for any other antibody, they do it only for capital D antibody. So if the antibody in your particular case is the capital D antibody and nothing else, then you can do an NIPT for fetal capital D status. Okay, but if there's one more antibody in the mother, you can have that. Many mothers do have multiple antibodies, especially if it's a 3rd or a 4th gravida. Then this does not help, because even if the baby is D negative, it could be incompatible for the other antibody that is there. So only if the mother is carrying capital D antibody, and that's the only antibody in the mother, then doing the NIPT probably makes sense. So our practice now is that we offer ICT to all women at booking. If she is ICT positive, we do the titers by both the tube and the gel method, because we still have an ongoing study. Otherwise, we would have just done the tube titers, because that's what we rely on for decision making. And we also simultaneously send for an antibody identification test. So by the time she comes for booking, I know if she is rhesus positive, I know if she is ICT positive, I know the titers, I know if the baby is at risk for anemia, and I also do an antibody identification test, so I know exactly what antibody I'm looking at. So this is what we call as triaging ICT positive pregnancies, and this is work in progress. We're trying to write this up and get this published as well. And as I said, if the antibody is only anti-D, we would still offer an IPT to assess the baby's blood group as well. Now this is a parallel that you can draw is the concept of inverting the pyramid of antenatal care. So what we are trying to do is triage these mothers, rhesus negative mothers or ICT positive mothers right at the booking visit, so that you exactly identify those subset of mothers who are likely to develop severe fetal anemia, and you train all your guns at those mothers and fetuses, so that you don't waste a lot of resources looking at mothers who are really not at risk of severe fetal anemia. Let me just give you an example. A 31-year-old 2nd gravida came at 18 weeks of gestation, negative positive couple. The first baby was positive, anti-D was given, but she became ICT positive in this pregnancy. Titers were reported as 1 in 32 outside. She kept following up 18 to 30 weeks every weekly, and thereafter with MCA Dopplers, there were a total of 13 hospital visits just for monitoring for fetal anemia. But this baby did not develop anemia till 36 weeks. So the doctor got confused and she referred to us for delivery. And we repeated the titers as is our protocol. Titer was 1 in 32 as was rightly done at the other center, but that was a gel method. We did it with the tube method. It was only 1 in 4, and the antibody was an anti-small e antibody. Now imagine if I had this information at 13 weeks, all those 13 or 14 visits that the mother had to undertake, all the anxiety that she had to go through, all the cost involved, everything could have been saved only if we had this information at 13 weeks, in which we could have had we followed the protocol that we now follow. So number of hospital visits and scans, the cost involved, the cost-benefit ratio, and of course, without saying, all the anxiety that the couple had to go through could have been avoided if we had triaged this ICT positive mother very early in gestation. Now the third key message is ultrasound monitoring for fetal anemia. Now you have an ICT positive pregnancy, you do the antibody titer and the antibody identification, you find out it's a strong antibody, you look at critical titers. If it's above the critical titer is when you know that this baby is at risk for fetal anemia, and that is when you start ultrasound monitoring for anemia. And in the ultrasound, what we look for is the middle cerebral artery peak systolic velocity, because if the baby is anemic, the viscosity of blood is low, there is increased venous return, so there's a hyperdynamic circulation, and therefore the MCA PSV is going to be quite high. And if it's above 1.5 times the multiples of median is when you diagnose severe fetal anemia. Or the thumb rule, if it's more than twice the gestational age, it is again suggesting that there is severe fetal anemia. Now we have to understand that one single MCA-PSV value is not enough, because MCA-PSV has a false positivity of around 12 to 14%. So make sure that you look at a trend of MCA-PSVs. We do 10 MCA-PSVs and then take the average value, because as I said, it can keep fluctuating. The baby jumps around, it can be high. If the baby has been quiet for a while, it can be low, and so on and so forth. If the mother is diabetic, you could have false positives. So there are lots of false positives. So you need to make sure that you look at the trend, and if it's persistently or consistently high is when you would suspect fetal anemia. Of course, you would not look only at the MCA-PSVs. You'll also look for corroborative signs in the fetus, like a placentomegaly. You look for enlarged liver, because you have extramedullary hematopoiesis that's happening if the baby is anemic. You could have polyhydramnios because of the hyperdynamic circulation. There's more blood reaching the kidneys, the GFR is higher, and therefore you have polyhydramnios. You could also have effusions into different body cavities if the baby goes in for severe anemia-induced cardiac failure and high drops. You could have ascites, which is often the very first sign. You could have pleural effusion, pericardial effusion, hydropic placenta, and so on and so forth. Now, when do you start monitoring with ultrasound? If you have a previously affected pregnancy, you start very early, at around 16 weeks of gestation. If not, if this is the first suspected case, you will probably start monitoring at around 20 weeks, provided, of course, your titer is above the critical titer, or if there is no unaffected pregnancy prior. Interval between two scans is individualized based on that particular risk scenario. If it's a very high probability of severe anemia, you would monitor closely 1 week. If not, maybe 2 weeks could be good enough. The fourth key message is, how do you manage fetal anemia based on the MCA-PSVs? Well, if the MCA-PSV is less than 1.5 moms, it tells you that there is no severe anemia. Above 1.3 moms is probably moderate anemia, but it's the severe anemia category that we're worried about. So if it's less than 1.5, you keep monitoring. If the MCA-PSV stays below 1.5, you can very safely take her and deliver at term. But if it's more than or equal to 1.5, then you look at the gestational age. If she's crossed 35 weeks, your neonatologist would be happy to deliver and transfuse postnatally. But if it's below 35 weeks or 34 weeks is when you have a real indication for intrauterine transfusion. Now, I do not have the time to go through the steps of intrauterine transfusions, because there are 15 steps that we follow, but I'll just focus on one step here, which is planning subsequent transfusions. So imagine you've sent them to D'Pankar sir or to Alkesh, and they've done an intrauterine transfusion, so the baby's anemia is corrected. Now, how do you plan subsequent transfusion as an obstetrician? Now, we mostly rely on the expected fall in hematocrit calculation, because remember, what you have pushed into the fetus is not fetal blood. You have pushed in adult blood, and the rheological properties of adult blood is not the same as fetal blood. So you cannot expect the blood in that fetus and the MCA-PSV in that fetus to reflect that of true fetal blood. So therefore, you would take a MCA-PSV with a pinch of salt after you've done a first transfusion. Rather, you would rely on the calculated or the expected fall in hematocrit values. Now remember the 0.4, 0.3, 0.2 rule. After your first transfusion, the hemoglobin falls by 0.4 grams per deciliter per day. After a second transfusion, 0.3 grams per deciliter per day. And after a third transfusion, 0.2 grams per deciliter per day. If you have to convert that to hematocrit, it is multiplied by 3. So 1.2, 0.9 and 0.6 will be your rate of fall in hematocrit after 1, 2 and 3 transfusions respectively. Now, why does the hematocrit fall? Is because the native blood of the fetus, which has the antigen, will still be attacked by the antibodies. The blood that you have given is O negative, so that will not be destroyed, but the native blood that is still there in the circulation will continue to keep getting destroyed, and therefore the anemia or the hematocrit will continue to drop, which is why you will need second or subsequent transfusions even after you have done one. But if you still rely on the MCA, there are guidelines that say you can rely on an MCA-PSV cutoff of 1.7 instead of 1.5 after your first transfusion. But beyond your second transfusion, I would strictly not recommend using the MCA for the simple reason that I told you earlier. You have completely different adult blood in the fetal circulation, and the properties are not the same at all. The fifth and the key message here is how do you plan delivery and neonatal management. It's not important that you transfuse and correct the anemia. Your peripartum care also has to be very, very planned and precise in conjunction with your neonatology team if you have to have a good long-term effect or outcomes for these babies. Now, when do you time delivery? If you've done a transfusion, you can time your delivery roughly 3 weeks after your last transfusion, because that's when, because at the end of the transfusion, you bring up the hematocrit to 45. So you give 3 weeks from there, you deliver, the hematocrit will still be around 10 grams percentage. So that is not severe anemia, and that will be a good time to deliver these babies at term. Now, we have to understand that you do not offer a cesarean section to all of these mothers. Labor induction is safe, particularly if you have timed your transfusions quite well, but you will always keep a low threshold for cesarean because these babies could be hypoxic to a certain extent. Now, we also need to understand if you have timed your transfusions effectively, you can avoid preterm delivery and take them very well up to term. Management of the neonate is equally important. The most important focus is not on correcting anemia, rather on correcting hyperbilirubinemia, because that is more of a danger here. The baby could end up with irreversible kernicterus if the bilirubin goes above, say, 12 or 13 grams per deciliter. Of course, you should also correct the anemia, but you would try and maintain a modest anemia in the fetus so that the fetal reticuloendothelium system is stimulated to produce fresh antibodies, fresh RBCs. If you completely top it up, the baby's endothelial response is subdued, which is not what you want. You want to encourage the babies to produce more and more new RBCs, which are not going to be attacked by the antibodies that are there from the mother's circulation. So intense phototherapy is generally the treatment of choice, and only if it's extremely high and not responding to phototherapy do neonatologists offer exchange transfusions these days. So you have to correct anemia to a modest level, but more importantly, you have to focus on correcting the kernicterus or preventing kernicterus by correcting the hyperbilirubinemia. For anemia, all that you would require is mostly a top-up, and as I said, you have to keep modest anemia so as to drive erythropoiesis. And once your lab tests tell you that the baby is starting to pick up reticulocytes, then further transfusion therapy is generally not needed. But we also have to remind our parents that the maternally transmitted antibodies can remain in the neonate circulation for up to 3 months. So the baby might go home looking happy, it might go home looking not anemic or not pale, but might come back to you 3 months later with florid heart failure, from which time it might become very difficult to reverse it. So this can happen. This has happened in our very early cases. This was 2014, if I'm not wrong. You can see I was much younger and had a lot more hair on my head. So this is one of our very early transfusions. Went home very well. We did 3 transfusions antenatally. Postnatally, the hemoglobin dropped again because the antibody was quite high. We corrected the anemia with postnatal top-up transfusions. The baby went home with a hemoglobin of 14.8 or something, if I remember right. And lo and behold, after that, they completely disappeared. So we had their number. We kept calling them because we knew this antibody titer was high, and therefore there could still be persistent antibodies in the fetal, in the baby's circulation now. So we wanted them to come back and check the hemoglobins. They never heeded to our calls. To a point, they started disconnecting our calls and they blocked us altogether. I don't know for what reason. So then 3 months later, the baby comes as expected with severe heart failure. And despite all our heroics of doing 3 transfusions, we lost the baby to heart failure simply because of the negligence on the part of the parents. Now, after that, we've been very, very proactive in counseling about this particular aspect, that look here, you need to keep following these babies. They will develop anemia sooner or later, so you need to keep following up for hemoglobin levels and bring them back if they need top-up transfusions after that. Thank you for your patient listening. I'll leave you with those messages.